And we're going to talk about the dental impact of Sjogren's today. So we're going to shift gears a little bit away from clinical trials and talk about the other important theme that keeps coming up, which is the quality of life impact on people living with Sjogren's. So we have two goals for this workshop. One is to explore real-world insights to foster a deeper understanding of the emotional and the economic burdens associated with dental challenges and their implications, and then also to engage in what I hope will be a candid conversation with our panel to bridge the clinical knowledge and with their personal experiences. Excuse me. So I gave our introductions. Just a quick overview of what we do at Trend. So we're really focused on of accessing data from social media. It's called social listening, and we're using AI to analyze those conversations to turn them into data. And I have this infinity loop here because for us, it's just as important to listen as it is to give back. So we don't just listen to listen. We want to understand the unmet needs of the communities that we serve, and we want to fill in the gaps in the medical and scientific understanding of these conditions. Excuse me. We've been working with the Sjogren's community for almost 4 years now, and I want to thank Amgen for generously supporting initiatives like this that are aimed at understanding the unmet needs of the community, and again, all of these wonderful things that we can do to raise awareness in the patient community, in the medical community, in the scientific community. So we've been traveling around the world, presenting at rheumatology conferences like EULAR and ACR, but also some of the conferences where won't generally find discussions about Sjogren's disease. We've presented at the World Orphan Drug Congress. We've presented at World Sleep. And some of the themes that we've been exploring together with our partners are mental health, again, the sleep impact. We've been doing a lot of work with Dr. Chiara Baldini and again, Sjogren Europe to understand the FLAIR lexicon, which we presented about last year. And our goal there is really to try to bridge the gap between the patients and the healthcare providers. So we really want to bring the lexicon of the community to the clinicians, but then also bring the medical terminology back to the community so that we can have thoughtful discussions like these. We've also been trying to understand the impact on activities of daily living. I think that this work can ultimately impact the development of better endpoints for clinical trials, to kind of bring it back to clinical trials. And today we're focused on the dental impact. There are some strengths and limitations to this approach, as with any research methodology. So a strength is that we have a lot of data and it's authentic patient experience. People going to social media to talk about their condition in their own words. There's reduced recall bias. It's happening in the moment. It's what they're experiencing. They're not being asked to recall what they experienced in the past. And we also have the ability to look longitudinally, both pre and post diagnosis, if the person has declared on social media when and how they were diagnosed. So that can give us some nice perspective into the patient journey. Limitations, there's of course a selection bias. We're tapping into the conversations of people who have access to the internet and who participate in social media. There is some language-specific nuance. You'll see for the work that we're doing here, we used Reddit, which is a social media platform. It's an English-only social media platform, so we all know that there is benefit to doing language-specific analytics, but for this specific work, we were using Reddit. And then, of course, there's limited medical context. So as much as we strive to connect the language of the community to the medical and scientific terms, we need to just take that into consideration, that these are anecdotes that are coming from patients talking about their lived experiences on social media. So I mentioned that this is from Reddit. How many people here have heard of Reddit? Show of hands. Oh, good. Okay, great. amazing. I'm glad you have. And so there's a really robust and active Sjogren's group on Reddit. There are 6,000 plus authors, so those are the contributors. The group actually has more than 13,000 members. That gives you kind of an idea of the ratio of people in the group to the people participating. We have data from October 2012 all the way to March of 2024. And you can see that we were able to identify some countries represented. In the case of Reddit, we can only know if someone's from a particular country if they self-identify as being from that country. But it can give us some insight into country-specific experiences. And then about 1 out of 3 of the 1 to 3, male to female. So 1 male for every 3 females, and the same thing. We can only determine that if it's disclosed. In this case, about 11% of people disclosed. So the real purpose of this, of sharing this, is really to foster discussion with the panel. I'm happy to talk more about the social listening work offline. This title is actually mislabeled. These are the top 10 topics overall. So you can see here eye care and dry eye management, support and encouragement, dietary restrictions, and then 4th overall is teeth and oral hygiene. So this is something that is discussed quite frequently on social media. And then in terms of the top topics within the dental, group, we have, these are the top topics discussed, and the deeper purple, the more that topic, the more questions there are in that topic. So dental issues, cavities, procedures, preventative treatments, and economic burden are discussed frequently. And then questions often revolve around generic dental problems and concerns, preventative care, and health insurance coverage. These are some quotes, just to give some context to the topics. I've spent over $100,000 on my teeth over the years, thanks to Sjogren's. Until my teeth started rotting out of my head from Sjogren's, I was never afraid of the dentist, and all my friends were. Also, I noticed that my teeth were a lot more sensitive when my vitamin D was really low. And did you find a treatment to improve your oral health after diagnosis? So I want to bring it back to the panel now. If we could start with maybe Anna or Joyce and talk a little bit about your dental journey in terms of Sjogren's and how it's impacted you.
Yes, of course. Can you hear me?
No.
No? Oh, yes. No? Okay. So I started to have cavities, plenty of cavities by the age of 12 and 13, although I had no dryness complaints. Okay, so if dryness was there, it was my normal. I never verbalized that I felt any dryness. But the fact was, it was very, very quick from the first cavity. So almost every teeth had cavities. And I remember that the dentist at the time asked my mom, "You're not surveying your daughter's oral hygiene enough, because this has to be a very not good oral hygiene." But the fact was the procedures were okay. My mom was there, but the cavities kept popping up. And at a certain point, I didn't, and they had to put the fillings, went to treat and by the time they were black, I still have 2 that are black from that time. And it really impacted my self-esteem at the time. I was a teenager, starting in teenagehood. I was afraid to smile, showing my teeth, even when talking, because it really affected my self-esteem. You know, all those black spots that were not cavities anymore, but were the treatments, the amalgamas. What's the word in English for? Is it
Amalgam.
Yeah. So it really affected, and the lack of solutions, that they kept insisting you're not doing your oral hygiene properly. And that was the solution. Do it properly and you won't have problems.
And how long did that go on before you had your Sjogren's diagnosis?
That went on until the diagnosis. So
And did you feel like once you got the diagnosis that people stopped, that there was, you had an explanation for the dental issues, or were people still focused on the hygiene?
I had the explanation, yes. I changed the dentist as well, and that was a game changer for me. So he wasn't that aware of Sjogren, but he looked into it. He did some specific training, so he wanted to learn more, and I've been with him ever since, and he keeps bringing novelties and other solutions. In fact, I have a bag there with toothpaste samples. He just gave me to share with other patients so they can take them and bring them to their home countries and test them.
Amazing. Those are the best doctors. Joyce, do you want to share your experience? Does that resonate with you as well?
For me, it was similar.
Oh, I think your microphone's not on.
Is it on now? Yes. Okay. For me, it was similar what happened to Anna, but I was older. I was about 25, I think. And by the time my old dentist stopped, and I got a new one, and so I had a lot of cavities. I had to stood up for myself because they said your oral hygiene isn't good, and you eat too much sweets, and so I had to keep a diary, and then I wasn't eating a lot of sweets, so that wasn't the problem. At the same time, I visited a rheumatologist, so I was in the beginning of getting the diagnosis, and my dentist said this isn't right. He said your saliva is thick, it's not normal, so see your rheumatologist and get a diagnosis. And then after quite some time I got it.
So was it the dental signs that led to your diagnosis, or was still quite a bit of time after that?
I think it was both a bit, and the oral problems I had and the visit to the rheumatologist, and that was combined, and I got the diagnosis. So,
Dr. Gonzalo, tell us about your experience, and are dentists or oral professionals, are they familiar with Sjogren's? It sounds like that could be a good opportunity to kind of catch it early.
Yes, I think many practitioners are not very familiar with Sjogren's, and because I come from a medical background and work in the hospital, we actually are part of multidisciplinary teams, so we are very familiar, and we end up seeing a lot of patients with Sjogren's. So for us in that setting, it's different, but the experience, the patient experience, the stories are very similar. There's a lot of oral health burden, a lot of caries, many years with history of caries and multiple dental treatments, and this complaint that dentists are not very maybe sensitive to the challenges that Sjogren patients face is very common, and the truth is oral hygiene is really the key, but the point is what is lacking is not the oral hygiene habits. The problem is you need different strategies for Sjogren's patients, because what they're most lacking is the saliva. and the saliva clearance is what makes most of the population don't have caries, not just the brushing, and that's what's lacking. And actually, most of my practice is targeted towards dry mouth and trying to enhance salivary flow, and that's one of the key areas. And adapting the oral hygiene care at home. There are a lot of strategies that many dentists maybe are not aware, and that's I think why it's important that patients are very well educated on those strategies, daily strategies to enhance oral health, so they don't have so much burden.
So we heard a lot about the economic burden. Is that because it takes so long to get the diagnosis, or is it generally because if they're doing the replacing the saliva and doing those things, is it generally pretty easy to then keep things in check, or is it still are they still at risk for a lot of dental issues even once it's managed?
I think every patient may have their own experience, but they're still at risk. But with the proper follow-up, the oral health can be maintained. And I think in terms of economic burden, the problem is, and it may depend on the country, is that dental treatments are very expensive, and insurance is not generalized for dental treatment, which is a problem because many times in terms of dry eye, there may be less spending, out-of-pocket spending, and with dental treatments there are not many programs to finance, and that's one of the problems. And for some patients, most of the economic burden may come from the oral health problems and not the rest of and that's one part of the problem. And other problems that I think are getting better, and we end up knowing this many times because of patients, is that some of salivary substitutes until like 2 years ago were not available in Portugal. We had patients that went to Spain to get them, and that's a problem.
Anna, can you share your experience with the financial burden?
In my case, the financial burden has to do with the price of this specific toothpaste, the mouthwashes, the saliva substitutes, because they are not reimbursed. So and they are not they are expensive. So and for many patients, they just don't buy them. They just can't buy them, and then there you have to visit your hygienist at least 2-3 times a year to keep a perfect oral condition, and to prematurely detect any problem so that intervention can be done as soon as possible, and that is costly, and you have to do it, at least in Portugal, in private practice. It's not available in primary care, for instance. Some hospitals in Portugal already have this specialty, but it's not open for everyone. It's like a drop in an ocean of problems out there. And then if you don't visit your hygienist because you can't afford it, you end up losing your teeth. And then there's the implant price is really heavy, the same for dentures. So it really impacts self-esteem and self-perception for patients who really can't afford regular visits to their dentists. But a game changer is really visiting regularly your hygienist, using the specific toothpaste that should be reimbursed because it's something essential. It's not a luxury. It's essential for our quality of life, for our well-being, and it's highly preventive of very complicated situations. And it's not only about implants, there's also another aspect. We have very receding gums, and I think many patients can relate with this because of the dryness. And aesthetically speaking, it's not nice to look in the mirror and see that you have these very receding gums. And there are some solutions for it, but again, very expensive, and you have to visit a private consultant if you want to find a solution for this. But I just can't afford it.
Yeah, thank you. Joyce, do you have anything to add to that?
In the Netherlands, we have, so in some cases, you get the toothpaste and the substitute saliva reimbursed, but a lot of people just don't know how to get that reimbursement. There is also some reimbursement in particular cases for implants as well, but the insurance companies, the healthcare insurance companies, deny it quite often, and you really have to stick up for yourself to get it, together with the dentist who is asking for the reimbursement together with the patient.
Right, and on top of everything else you're doing.
Exactly, and you know, patients are quite fatigued, and every time when it's denied, they feel so defeated and they just give up. So it's horrible, I think.
Oh, sorry. Well, that brings us to the emotional impact that the dental issues have on the Sjogren's, people living with Sjogren's. And so we found that fear was the most prevalent primary emotion that was mentioned in these dental conversations, followed by disgust. These are 6 primary emotions that we map to. Can you, I mean, it's kind of coming through loud and clear, but speak a little bit more about, we've talked about stigma and your experience with the dentist and your feelings about your physical appearance. Tell us about the emotional toll that takes on you.
So there's a huge level of uncertainty in this disease. So you never know when a complication is knocking at your door, and we do fear losing our teeth. And now, and a person without teeth, I think everyone in the room can relate how that will massively impact your emotions, your mental health. So it's fear in various layers. If you see fear as an onion, for instance, you know, there's various layers of fear of losing your teeth, of having a complication and not being able to afford the treatment, lack of support in governmental institutions, healthcare providers. So it's basically all private, at least in Portugal. There's not even we have it for children in Portugal, the dentistry check. They can use it every year for whatever they like, treatments or the cleaning, but we don't even have this for these patients. It could be a nice thing, and we're not, this is not a disease that has a high prevalence, so I don't think this will impact seriously the health budget, but would be very, very good for patients in preventing things as a cost, but later not preventing them as a much higher cost. So we should make payers and governmental institutions, decision makers see this as well. Not to mention the emotional side of it, you know, your mental health. Will you allow me just to share? Sure. I've seen on a Sjogren's blog yesterday, so it was 15 hours ago, this comment. I was so disappointed when I saw my dentist yesterday, and told him I have severe dry mouth, that all he gave me was Colgate for sensitive teeth toothpaste, and told me to make sure I drink plenty of water. I was so hoping for more advice on how to help with horrible symptoms of dry mouth.
Wow.
I think this says it all. You know, you feel so isolated. It looks like there's no one listening
Right.
to the root causes of this, you know?
Wow. Thank you. Thank you for sharing that. And I think it speaks to why it was so high in the conversations that just happened yesterday. Joyce, so you talked about, it sounds like there's more support in the Netherlands. There's a lack of awareness about how to get that support. Do you still feel the emotions that we see associated with these conversations? Does that impact you as well?
Yes, of course. And it's, you know, a lot of people just don't know how to get the reimbursement. And that's, it makes such a huge impact on your life. For instance, when you just have visited your dentist and the next day something happens and, you know, you look in the mirror and teeth are falling out and it's so horrible. So the emotions are there for everyone, I think.
Dr. Gonzalez, how do you experience that sort of mental health side of things in your office? Do the emotions come through with the patients that you see?
Sometimes I think not every patient maybe shares maybe their more personal fears, I think, in the appointments, but still it's a reality that patients fear about their oral health, and I think what Anna was saying is very true. I think the healthcare system is still not very aware, and the truth is, for a very large group of Sjogren patients, oral health is one of their biggest complaints. Not for everyone, but for a big group it is. And I think we need to work towards making this kind of care, oral care, available for Sjogren patients. And it's true that's still not widespread available in Portugal, but there are already some groups working on it. And I did my formation, my specialization in the biggest hospital in Portugal, and we had a very good multidisciplinary team. And now I'm in the Western Lisbon. It's a little smaller, but we already, with a rheumatologist that also came from the same hospital, we already started a multidisciplinary team there. And I think these are the kind of examples that need to follow. And we actually need to raise awareness, because what Anna was saying is true. It's not very expensive, the preventive care, and that will have really a big impact. And I think decision makers, and it's also an industry problem. I'm not saying the industry is the problem. Industry most of the time is the solution, especially in these rare diseases. But the problem is, right now industry is focused on the part of the treatment that is very important, is biologics, but they have a very return on investment, let's say, and the oral health part doesn't have. And I think it needs to be the Sjogren Europe, the patients associations that have to raise their voice and ask for this and work with the medical community.
Yeah.
And I think we actually need to solve this in Portugal, because I actually see this is a problem, especially because we don't have these multidisciplinary teams in every hospital. And me having experience in 2 different hospitals with appointments with more with 200, 300 patients, which in Portugal is a lot. And the experience is very good. There are some patients that are that have good care in these centers, and I talk with some colleagues in other hospitals, and they don't have anything like that. And also I see a lot of patients in my private practice that also don't know this kind of teams exist in the national health system, and many times I send them to the national health system because all the care of all the specialties needed that these patients need, it becomes a real economic burden. So just saying that especially in oral health, I think patients have to work with decision makers and policy makers to find a solution to this.
Yeah, it seems like in Sjogren's, it's not just a dental health issue, it's a medical health issue, and it needs to be sort of framed that way. We have about 15 more minutes, open it up to the audience. If anybody has any stories to share, questions for our panel, you can raise your hand. Over here.
I started having cavities when I was 6 years old. And I was also tested for diabetes when I was 12. And nobody connected this because I was so young. And what can be done, I think, about children having Sjogren's, because the impact is bigger than if you get a diagnosis when you're older.
Wow, it gives me chills. It's a great point. Thank you for sharing. Anyone else? Are there any other dental health experts in the room? Probably not.
Kind of toothpaste, pilocarpine-based toothpaste. I'm coming from Athens. I'm going to give a presentation just after Maria's one. We are going to give a presentation, in fact. And the only thing I would like to add, I'm a Sjogren's specialist. I see patients every day. Dental issues are so important, and starting from diagnosis, patients go to the dentist, and many times the dentist doesn't see the problem, doesn't feel that this is Sjogren's. Mm-hmm. So we lose some valuable time from that point on. However, as the clinical course of the disease moves forward, we see problems that in some patients are one of the most disturbing ones. So we are focusing on that issue, and we are trying to create a toothpaste that you're going to use 2 or 3 times per day, and it's going to have a pilocarpine-based regimen inside, so that in addition of protecting your teeth, also increases the saliva in the matter of possible. We still don't have any results. We are still in the manufacturing process. I hope we have some good results and make a small contribution in the field.
Great, thank you. Over here.
My problem, since I remember myself regarding the oral area, it was the ulcers. I had terrible problems since I was a child with ulcers. My mouth was full of ulcers all day, all time. I had ulcers on my tongue, on my lips, everywhere in the mouth. I couldn't eat, I couldn't drink. I was very thin when I was younger, of course. But and everyone said that I was not doing proper hygiene, or it's because I was too anxious. I have terrible anxiety, and what's the matter with a child to have anxiety in order to have ulcers? Nobody get in trouble to try to find out why I've got ulcers. They don't even bother. No one, even dentists, even doctors, even anyone. Until I got almost 40 years old, in order to a dentist propose me some products, I don't know, I will tell the name because the Xerostome products, I don't know if you have them in your countries, but it was a life-saving for me because from the time I started using them, because it has pastilles for dry mouth, it has mouthwash, they've got toothpaste. From the time I started using them, especially the toothpaste, it was a relief for me because I really stopped getting ulcers. And this is a life-saving for me because I have no problem to eat properly and drink properly. I couldn't even talk or I couldn't even do my saliva. I couldn't do anything until my 40, even more than that. But around, I think, I'm 50 years old now, and I had to wait until 40 years old for a doctor to suggest these products in order to get rid of ulcers. I've got the dry mouth, of course, and all the other things, but the more important for me were the ulcers.
Thank you
In
for
my-
sharing.
Yeah.
Maria,
sorry.
I think we have two very important testimonies in that table that they both popped up in childhood very early on. So maybe the medical community, we need to raise awareness that if dentists or primary care doctors, because they are usually the first door we're going to knock, see children with cavities, ulcers, please refer them to rheumatology just to make sure it's not childhood onset Sjogren's. So they don't have to wait decades to be
Absolutely.
diagnosed. And imagine these children, these two ladies, in the time they are starting to build up their personality, living with the emotional burden of not being able to speak, to hit. I have no words for this.
Nobody was listening. Nobody. Everybody said that it was mentally. Everybody said it was bad hygiene. Nobody bothers to see what was behind that.
Yeah.
This is the important, and I agree with Anna. The awareness. The thing is that sometimes, I don't know in other countries what happens, but in Cyprus, whenever we call the medical practitioners to be in a conference, they are not very much interested to be informed, really. And this makes our work even harder, how to do this awareness, to
I mean, I
find...
think even awareness with pediatricians, right?
Yes,
Yeah,
yes.
mothers. I mean, I'm
Yes.
thinking, yeah.
Yes, yes. Pediatricians, medical school. I will be more bold. Medical school.
Yeah.
Give them real examples. Have them talking to patients.
Absolutely. Dr. Gonzalez, we have some more, another.
Problem is that the dentists and the doctors, they don't speak to each other.
No.
Right.
So if I had cavities and then I was tested for diabetes, nobody could connect that. I was 32 years before I got the diagnosis. So
Mothers. We need to inform mothers.
As well.
And fathers, sorry. Yes, and fathers, parents. Dr. Gonzalez, do you have a sort of a closing thought?
Yes, I mean, what we heard is a story that unfortunately I think it's quite common to many rare diseases because most times the only only healthcare provider people see when they're young and when they're healthy. It's the general practitioner, and many times they're not very aware. There's also the problem that the medical and the dental community don't talk that much, and it of course delays all the oral diseases, the diagnosis. Um, what I can say, it's important for advocacy to find these multidisciplinary teams. I can say that in the hospital settings that I've worked, our appointments on our departments contributed like 1/5 of the new diagnoses, because most diagnoses are done by the rheumatologist, of course. But when you have a multidisciplinary team and when you have professionals that are focused on dry mouth and on these rare diseases, you end up doing a lot of diagnosis. And it's important because in a private practice clinic, a dental clinic, you won't have that. And there's also the problem that mouth ulcers, oral hygiene problems, cavities, most dental practitioners won't be motivated to try to find the root cause because it's not very financially motivating, let's say, and that's a problem we see. Dentists want to put another implant, maybe they want to do some crown work, they don't want to know why you don't have a lot of saliva, or why you have a mouth ulcer, or why your mouth is always burning. Most of them don't know what burning mouth syndrome is. They don't even know that Sjogren patients have it, or that lack of saliva may contribute to it. And so it's a complex disease, or systemically speaking, and even oral, or in terms of oral health. And you really need to have these multidisciplinary teams, and it's an example to be followed everywhere. And I know that in other countries there are also, and I think you have to push for at least central hospitals to have this kind of teams, because they're very important.
Thank you. Joyce, final thought?
Perhaps I can just share one thing we are going to do with our national organization. We are, not we, but people are developing new recommendations for the treatment of Sjogren's, based on the EULAR recommendations that are there. And we as a national organization are planning to disseminate this to the GPs and all dentists. And we're going to do that via a podcast. So perhaps next year we can share the results of that.
Amazing. Well, thank you. Thank you to all our panelists and all of you for sharing so candidly. Appreciate it. Do you want to sit? Do you want to sit? All right. I'll be with you for the next hour as well. So I'm excited to introduce Lucas Hachis.
Lucas Hachis.
Okay, thank you. Sorry.
Good try.
They told me just to call you Lucas. I should have done that. He's a medical doctor at Lyko General Hospital and an academic fellow at the University of Athens. And we are going to talk about demystifying clinical trial results access and interpretation.
So hello everybody. I'm so pleased to be here with all of you today. And I would like to thank the organizing committee once more for this kind invitation. Thank you, Katie. Thank you, Anna. It's such a delight to be here with you, even at the last minute. I just arrived from Athens. My name is Lukas Hadjis. I'm an internal medicine doctor. I work more as a rheumatologist, and my special field of interest is Sjogren's disease, both from the translational and clinical perspective. I just want to share that I have been worked with in many clinical trials as a PI, as a sub-I in phase 2, phase 3, and phase 1 with the pilocarpine tooth-based clinical trials in Sjogren's disease and beyond. And today we're gonna start with a small summary. I know you've talked about all these things, Maria, but a small summary is always good about the phases, the phrases, and the basics of clinical trials. And then we're going to go through together trying to understand how to read and interpret a clinical trial so that it stops being like a textbook in a foreign language, like you're trying to uncode the Da Vinci Code or you're lost in translation. We're trying to make it simple so that you can really go through a clinical trial. So let's go back in time, almost 10 years ago. This is a photo from my graduation, medical degree graduation. And I was surprised to find out that every doctor around the world had to give a promise, an oath given by the doctor to the patients. An oath primarily developed for the benefit of you, of the patients. An oath that for the last 2,500 years guides our good medical practice. And inside that oath, there is a phrase that says that every doctor will use the drugs for the benefit of the patients according to his best judgment, and he will do no harm. Primum non nocere in Latin, ophelein imi vlaptin in Greek. But how do we know that what we suggest, that what we do is really for the benefit of our patients? How do we know that the interventions we suggest do not make you feel worse, in fact? How do we know that we follow that sacred oath we all have given? And after many, many years, thousands of years, the medical community and humanity in general has concluded that clinical studies is the way to go. So a clinical study is a systematic investigation into human subjects to see whether an intervention, and this intervention can be a pill, a novel IV drug, a repurposed pill, but can be non-pharmaceutical. It can be an endoscopic procedure. It can be behavior. It can be nutritional. It can be yoga. It can be anything. Whether this intervention is for the clinical benefit of our patients. And please remember that when we talk about clinical benefit, we don't mean difficult to pronounce and difficult to calculate composite indices like the ESSDI. We talk about two things: living longer and living better. Living longer is not a huge problem for Sjogren's, but living better it is. So the drug development process is long, it's complicated. You've talked about it, you've seen many iterations like this one in this conference and then elsewhere. I really like this one. We start with more than 10,000 compounds. After 10 to 15 years, we end up with just one. 2 to 3 billion spent. And it's really amazing. It's incredible the amount of work that goes through the process, the amount of collective intelligence that goes through the process, and of course the contribution of our patients. We start with phase 1 clinical studies. Phase 1 clinical studies is the first assessment of a new drug into humans. They're usually small, around 10 to 15 patients. They're quick. They take around 6 to 12 months. And we want to assess safety. That's the main goal of phase 1 clinical trials. And also determine the dose for the phase 2 clinical studies that instead of safety, we also look, not instead, in addition to safety, we also care about the effectiveness of the drug. That is why phase 2 clinical studies take a little bit longer to be conducted, and they include a little bit more patients around the low hundreds. Phase 2 clinical studies want to find the minimum effective dose, maximizing the effectiveness while minimizing the side effects. We have some fine-tuning in the dosing, and then we move on to phase 3 clinical studies. These are multi-center, randomized, including hundreds or even thousands of patients. They take longer to be conducted, maybe 3, 4, or even longer, and they confirm the efficacy and safety seen in the signal of the phase 2 clinical trials. And we also care about generalizability of the results. We want to see broader than the hundreds of patients that were included in the phase 2 clinical studies. Of course, there are inclusion criteria. You talked about them. I just want to mention diversity. Diversity is really important for clinical trials because we need to see clinical trials that represent the real world. Not everyone is the same. Informed consent, you also talked about it, correct, Maria? It's very important. It's not obligatory. It's not, you may sign a huge document including 70 pages, but you can stop the trial whenever you want. It's not something that really, it's not a legal binding or anything like that. So, phase 3 clinical studies, or late stage clinical studies and some phase 2 clinical studies, how are they organized? Usually, we divide patients into 2 groups. One group is called the treatment group, and the other is called the control group. A computer is used to randomly assign each patient to the treatment or the control group. This process is called randomization, and it is very important because it protects us from biases, since neither the patient nor the doctor knows which treatment a patient is assigned to. And randomized controlled clinical trials over observational data have 3 virtues. First of all, they control for unmeasured confounding. Yes, we can balance for the factors that we know, but we can't balance for the factors that we don't know, and observational data just can't do that. And this problem really plagues over observational studies because we just don't know what we can't measure, and we do a really bad job measuring socioeconomic factors. We do a really bad job measuring behavioral status, nutritional status. So randomized control trials give us this opportunity to have a balance of measured and unmeasured confounding. It also anchors time zero. This gets a little bit technical. We start the treatment at the same time for all patients, and it also controls for multiple hypothesis testing. So, in many clinical trials, we add a treatment over the existing treatment. So the control group usually receives standard of care plus the placebo. So what is the placebo? Placebo is a drug that looks, feels, smells, senses exactly like the new drug, but it's completely inactive. We also call these trials blinded, meaning that either the patient or the researcher doesn't know which patient is assigned to which group, treatment or control group. It's called either singly blinded, meaning either the patient or the researcher, or double blinded, meaning that both parties are unaware of the assignment of the patients to the groups. So, our first conclusion: the most reliable results come from treatments that are double-blinded, patients that are randomized, and trials that have a control group. This is called double-blinded, randomized, control clinical trials. So why do we need randomized controlled clinical trials. Let's see the difference. We have a treatment group that includes, in the effect sizes, the Hawthorne effect. Does anyone know what is the Hawthorne effect? It's the difference in our behavior when we know that we are being observed. We change our behavior. We know that from our children or our pets. Regression to the mean. Does anyone know what's the regression to the mean? It's very important for Sjogren's. When we choose patients that have a characteristic that diverges from the average, just by chance, this may follow back to the whole group of the average. So this is important when we have very selected patients. The placebo effect, you've probably heard about it. It's the effect that can be attributed to the anticipated effect. It can be positive, usually, but it can also be negative. And the true therapeutic effect. If we only had the treatment group, we wouldn't know the real allocation of these factors. We need the control group. Only if we have the control group, we can see what is the noise and what is the real difference. We can be sure that this drug really makes you feel better, or at least doesn't make you feel worse. Maria,
Yes.
what do you think?
As I didn't share previously when I introduced myself, I also have a child with a rare disease. She's 12. Like Sjogren's, it's very heterogeneous. I was telling Lucas about the cool exercise that we did earlier with the, giving the word cloud for placebo. And people shared things like fake, bummer. There was a lot of negative sentiment towards the placebo. So I guess the first question is, this is a talk about interpreting the results. And we wanted to kind of bring it down to like, how do the results pertain to me? Can you talk a little bit about, why is this design so important? Why is the placebo so important? And what would happen if we didn't have it?
Yeah. We wouldn't know, just if I want to wrap things up, we wouldn't know if anything is of help or not. If we just had the treatment group and no placebo, no one could guarantee whether the effect we see is because of the placebo effect, is because of the regression to the mean, it's because of the Hawthorne effect. We should have a comparator to be able to understand whether the treatment is of any good or make you harm. So we can't be sure the control arm is necessary to validate the results of a treatment, of any intervention into human subjects. The thing that I want to add is the fact that if we don't have a control group, it's not a matter of if we have or we haven't a control group. It's a matter of having the optimal treatment in the control group. Patients may be afraid of the control group because they feel they may be undertreated. This is the most important thing. Even if you are in the control group, you should receive the standard of care. For Sjogren's, it's just placebo, but this is not a discussion just for Sjogren's. There are clinical trials in cancer. When we say that a patient with a cancer, with a metastatic cancer, gets into a clinical trial, he may get the new treatment, that's hope, but if he gets the placebo, he will still receive the standard of care. And we will talk about it in the next few minutes. If we are sure, and our doctor and the patient advocacy groups see with a critical eye all studies, one of the questions is whether the control group receives the optimal treatment with the placebo. If we understand that, all the fear that surrounds the idea of the placebo will go away. We just know that we are receiving the best possible care, and we have the opportunity to receive an even better care. But in the situation that we are assigned to the control group, we will still receive our standard of care. For Sjogren's, unfortunately, this is just placebo, sugar pill. But that's the situation, unfortunately.
Thank you.
Where can I find the results of a clinical trial? A burning question. I think the most obvious answer is through my doctor. My doctor should be abreast of all the clinical trials in my disease area. And if the doctor is hesitant, just ask him. Go and ask, hey doc, do you know of any trials that are recruiting, that are active, that have been concluded and have been conducted and we know the results of in my disease? If he's unaware, maybe you should look elsewhere. There are also, the results usually get announced in big conferences. This is where we learn about new data. In rheumatology, this is the ACR and the EULAR. Then, there the embargo is lifted, the investigators can speak about the results with liberty, and we usually learn a glimpse about the results. There are also online registries. The clinicaltrials.gov, clinical trials should have all trials that are enrolling, all trials that are active, and all trials that have been concluded. There you can learn about the results. Has anyone go through the clinicaltrials.gov? Yeah, it's quite a complicated website. That's not really easy on the eyes. It's heavy, it's clunky, but there are some useful information. You can navigate through the information, and you can also find the contact information of the principal investigator and reach out to him. And trust me, he will be more than eager to answer to all of your questions. And finally, we end up with a publication. And in the next few slides, we will try to get through how to read a complicated publication. At this point, the patient advocacy group role is more than important. The patient advocacy groups should translate clinical trials that have been published in clear, jargon-free language, and even translate it in different languages so that everyone has access to the results in lay language. It should also create campaigns, social media campaigns, taking advantage of the millions of people that are on social media and do not get to the groups we create, and create open avenues of contact so that forums or helplines or, I don't know, open contact from the patients to the doctors, to the practitioners, to the epidemiologists, so that we can come back with follow-up questions if we don't understand everything at the first time. So I think the role of the patient advocacy group is really important. Maria, what do you think? How can we improve, and everyone, how can we improve what we do as patient advocacy groups when it comes to accessibility to the results of clinical trials?
Yeah, I think certainly the advocacy groups play a critical role, but I think also pressing their industry partners to publish in a timely manner, even if the results are, even if the trial fails, that's important.
We will get back to that. What happens when the results get failed, with some really nice examples. But when the results are published, then it's important to spread the word. If there is a new treatment, if there is a new option, if there is a better treatment, a cheaper treatment, we should make patients know about it. In patient advocacy groups, the doctors and the patient itself is the way to do it.
And the lay summaries you mentioned are very important.
Lay summaries, of course. Also, the industry creates usually some lay summaries after the trials are concluded, and that is a very good addition, I think, to the process, and really helps the patients learn about the clinical trials.
Lucas, one more thing. We had one person who participated in a clinical trial, Anna, shared her story about her frustration trying to get access to her clinical trial results. Is that a thing? Like, how can patients get access to their results? And is that something that would be dictated in the informed consent? How does that work?
It's dictated in the informed consent, and it's true that at an individual level, it's quite hard to learn the results of the of your participation in a clinical trial. There are some exceptions, like you can learn about some biomarkers if you are into the genetic fields. You can learn about some predisposition for a certain diseases, but usually there is no legal framework for when you can have access to your personal results. In general, when it's a matter of safety, there is what is called unmasking. So you learn about whether you were in the treatment group or not, but that's only for safety reasons. There's not like a pipeline that you know that 2 months after the trial you will be concluded, you will learn about all the tests you've been through. There can be biomarkers, there can be blood tests, there can be patient-reported outcomes, whether you were on the treatment. There are different reasons, various reasons for that. And that's it. So there is no like an easy road to get your access. Yeah, Anna. Yeah.
Please. No, great. We actually wanted.
Yeah,
I should have.
That's a workshop.
Yeah.
It's not a presentation. It's a workshop. So it's better if we like discuss.
So lip biopsies were optional in my trial. It was a phase 2, but I've decided to
go through,
because I'm aware that you can get information from those biopsies that is not elsewhere on blood works or whatever. And I have asked my doctor, because he was also interested, to have the results of these biopsies, and they have been denied. And I find that this information is important for me, not only for prognostic reasons, but also for informed decision-making in the years to come. So it's useful for me, and it's useful for my doctor and the team that follows me up at the hospital. But I have been denied. The PI, which was my doctor, asked the sponsor for the results of the lip biopsies, which were not mandatory. So I voluntarily applied and agreed to do these biopsies, but then the results were denied. Even I ended up with my doctor telling me, maybe if you ask yourself, you will be luckier than we were.
It's ridiculous.
Yeah.
It's ridiculous. That's the only comment I have. I can make. This goes beyond blood tests. This is still your tissue that you are donating, so you are entitled to the results. You are entitled to the tissue. It's ridiculous.
We talked about advocacy organizations playing a role in reviewing the informed consent and the protocol, and we also talked about by the time they get it, it's sort of fully baked and it's kind of a checkbox. But would that be something that maybe the advocacy organizations could become a little more savvy around, if there are especially non-mandatory test results, to bake that into the protocol?
Yeah, I think it's a general discussion that goes beyond the specific, whether the raw data of the clinical trials that includes every data should be publicized or should be given to the participants. I think the answer should be yes, especially in such situation. But in general, I think being open and being honest is always good at the end than being trying to hide things for safety concerns or other things that may the industry think about.
Corley?
Yeah, sorry, if I may add a comment. I think it's a great opportunity for us, patient association, to help for communication, and that will help also to facilitate inclusion of patients.
Yeah.
We were talking earlier of patients being seen sometimes as guinea pig. An example like the one Anna gave to us is unfortunately preventing more patients to be involved. So I guess that we all stakeholders need to work on transparency. because if other patients take Anna's comment into consideration, unconsciously they will have an hindrance or a barrier to participate because of this lack of transparency. So I think it's a topic we should all, with our partners, pharma companies, with you as a researcher, we definitely need to work on it.
I agree.
Yeah, you nailed it. Transparency is a problem and creates this notion of like a clinical trial make us a guinea pig, or clinical trial is a last resort. It's not like that anymore. Clinical trial is made just to make you feel a little bit better. It's made to make an add-on on your treatment regimen and make you feel better. And creating these barriers and these walls when it comes to the accessibility to our data only creates problems and doesn't solve. So I think that patient advocacy groups, along with researchers, along with clinicians, and along with the industry, we can work on that. We can work on the transparency. And now let's switch gears and let's talk about how to interpret a clinical trial. This is a quite difficult topic. As an individual level, not as a group level, how can we really get through these 7, 8, 9 pages textbook of a clinical trial? And the way to go is to try and answer with some simple questions the results that you're reading. Why the trial was done? Who was included? How the trial was conducted? And what does it tell us? What is the result of the trial? And as a common denominator for all these questions, we should use our common sense. Our common sense is the guidance trying to answer all these questions. And I want to start with a systematic review that was published a few years ago in BMJ, one of the most prestigious medical journals. And the researchers tried to examine studies that looked at the effectiveness of a parachute to prevent major trauma after a free fall. They tried to find whether there is any evidence in the literature. They were unsuccessful to find one. So they suggested that we should create a randomized clinical trial to see whether parachutes really work. Of course, they do that just to underscore the fact that even though clinical trials are important, even though clinical trials is the cornerstone of evidence-based medicine, it's not the solution to any research problem, especially if the outcome is self-evident. So for medicine, where we have a putative marginal to modest effect size, randomized clinical trials are important. If we have an effect size that is of such of a parachute-like, that you raise the probability from almost 0% survival to 99.999997, you can die with a parachute, but it's almost impossible, then you don't need scientific data, you don't need evidence-based data, you don't need statistical analysis, you can see it with your naked eye. Unfortunately, in biomedicine, most of the things we do not have a parachute-like effect. Most of the things we suggest, the new treatments, have a putative, modest, marginal, if any, effect size. So this is why we need randomized clinical trials in biomedicine. So we will begin with the why. Why the trial was performed? Is there a knowledge gap in the literature that the investigators try to fill? Let's take the abatacept trial, for example, for Sjogren's disease. It's a new treatment, a repurposed treatment for Sjogren's. Do we need new treatments for Sjogren's? Of course we do. Sjogren's doesn't have a treatment. So it's a pressing and logical endeavor to try to find new treatments for the disease and see whether these treatments are safe. So why? Always use your common sense, and you can judge just from the title what the investigators had in mind. who was included. The inclusion and exclusion criteria of the clinical trial. A clinical trial can be meaningful and generalizable only if the inclusion population really represents the broader population of the disease. So in this specific trial, only patients with moderate to severe disease activity were included. Is this the majority of patients with Sjogren's? No, 30% or even less. So the question now becomes, what is the population that this trial should create the inclusion criteria so it is well suited? It is very, if the criteria are very narrow, if the criteria is very limited, then the results can't be attributable to the broader population of Sjogren's. For example, if you are a patient who has constantly low disease activity, the majority of patients, and high symptom burden, do the results of this trial be applicable to you? No, no. So after understanding the why, we should see the who. Is it representative of the population of the disease? And at an individual level, is it representative of me? Could I have been included in this trial? If the answer is no, probably the results do not apply to myself. I can skip this trial. And this has been a problem for Sjogren's. Let's talk a little bit for the specifics of the disease. Because we are trying to select patients. Because of the deprivation of treatments, we are trying to select those patients that might be effective, might the treatment be effective to them. We have divided them based on the disease activity and the symptom burden, as you all know. And at first, we used the majority of patients in clinical trials. This failed miserably. Then we said, let's focus on the 30% of patients. Some trials had some positive effects, but right now we're moving forward. We see some new trial design. It's called umbrella design, that practically is two trials run in parallel with inclusion criteria that is mutually exclusive so that we can include more patients with Sjogren's, not everyone. These patients are still left outside, but the majority of patients are included in this new umbrella design. And one of these trials is the dazodalibep trial. You can see two different populations, one with a high disease activity, the other one with a low disease activity, but high symptom burden. So after establishing the why the researchers tried to do the trial, the who was included, now the most difficult question is the how. How the trial, what are the secrets of the trial, how the trial was conducted. We can see here two different groups, starting from day one, two groups, one treatment group receiving the new drug, the other one, the placebo, for 169 days. That's okay. And then we have a new term. It's called crossover. What is the crossover? The group that was on dazodalibep started receiving placebo and vice versa. So everyone was both on the new treatment and on the placebo. At this point, a very important question to ask is, what is the control group receiving? For Sjogren's, up to this point, it's not a very important matter because we have no treatment, so the control group is always receiving placebo. I hope this will change in the next few years, so it's good to be educated. We should always look on the quality of the control group. And as an example, I'm showing a trial about heart failure that was published a few years ago in the creme de la creme of medical journal, the New England Journal of Medicine. So this trial tried to see whether a new heart failure regimen called neprilysin inhibition and inhibitor improved outcomes. And the results were so amazing. So there was a reduction in all-cause mortality in patients with heart failure and hospitalization and heart failure. So what did the researchers do? They randomized patients, as stated previously, into two groups. One group received the new treatment. This is called sacubitril and another antihypertensive drug. So they received two things, Y and B. They wanted to see the effectiveness of sacubitril versus, of course, the other hypertensive drug, to see whether adding in the treatment a new drug really improves outcomes. But this is not what they did. They gave for the control group another antihypertensive treatment, and not at the same dose. So the treatment group received the maximum dose of the second drug, while the control group received half the maximum FDA dose. So we should be really skeptical, and we should see whether the control group is really receiving the treatment that they should. Do they really receive the standard of care? And a clinical trial can only change the standard of care only if the control group receives the standard of care. And in rheumatology, we fail many times on choosing the optimal control group. This is a trial about psoriatic arthritis, active psoriatic arthritis. The guidelines are very clear. If you are intolerant or non-responsive to a DMARD, you should move on to a biologic. What did the control receive? Placebo. Rheumatoid arthritis, active rheumatoid arthritis, irresponsive to methotrexate. What did the control group receive? What is the guidelines? From 2008, if you have a high disease activity, you should go to get an anti-TNF. What did the control group receive? Placebo. Even trials with aggressive diseases, that JRA with fever. What did the control group receive? Placebo. So I think it is of the utmost importance to focus on the control group. If the control group is receiving the standard of care, there is no issue getting into a trial. If the control group doesn't receive the standard of care, then we have a problem, both interpreting the results or getting into a trial. Maria, I think the value of the control group, of using the optimal control group, is of the utmost importance. Not right now for Sjögren's, but because for Sjögren's the optimal control group is still the placebo, but this will change, and we should be prepared to ask for the best treatment. And this, again, will make us more comfortable getting into clinical trial.
Any comments, questions?
Yes.
Sorry, but just realize that most of the trials, the control group is getting placebo.
Yeah.
What you are telling us right now, that is most of the trials.
Yeah, most of the trials, I don't know if it's most of the trials,
All the trials.
but there are many
Many
trials, especially in rheumatology,
Yeah.
that the standard of care, that we don't follow the guidelines. And this creates confusion, this creates doubt, and this creates a problem when interpreting the results as well.
This is what I mean.
It's a problem of not having head-to-head trials in rheumatology. I don't want to get don't want to get too much technical, but we need and we should be prepared in the Sjögren's community, the patient advocacy group, the doctors, to ask for trials that are well designed.
So the results of the trials getting the diabetes control placebo are not so reliable.
No,
No,
they are,
Patti. So I think what he's trying to say is, so he's advocating for the placebo
Yeah.
arm, but that the people getting the placebo arm should also get the standard of care. So in Sjögren's, since there's no treatments yet, then you would only get the placebo, but that there should be an insistence that the people participating in the trial getting the placebo should also, at a minimum, be getting the standard of care.
Yeah. Yeah, and they don't. And they don't always do in rheumatology in general, if we look at the whole picture. And they even don't do it in cancer. In cancer research, always, sometimes, at least. So we should be really careful, we should be really critical when we judge what is the control group. Just put ourselves in that position and see whether with the control group, if we were to receive the treatment that the control group receives, would we be happy? When the control group is approved, then we can move on to the results of the study. This is the table 1. There's always some general characteristics about the treatment and the control group. We don't need p-values here. This is the magic of randomization. If the randomization has been performed, then there is like a balance of all of the outcomes rather than a balance of all the possible variables we can see. I'm getting a little bit technical, I'm sorry about it. So we can see the table 1, there are a summary of the main characteristics of the two groups, and then we can move on to the primary endpoint of the study. This is the most important fact. This is where we can see whether the drug, whether the intervention really worked. We are trying to find these little stars. If we see these little stars, it means that there is statistical significance, but that's not all. We should ask, what is the endpoint of the study? Is it a clinical endpoint or a surrogate endpoint? And what is a surrogate endpoint? It is something that is not intrinsically meaningful to patients. It is something that is a stand-in for that should become earlier and have some correlation with what the patients feel. For Sjögren's, does the ESSDAI has a correlation with what is important for you, living longer and feeling better? No. It is a surrogate for the doctor, for the doctor's feelings. If the ESSDAI goes down, the doctor feels well. It's not a surrogate for the patient's feelings. So the levels of endpoints is a matter that it is very difficult. We start with the all-cause mortality. All-cause mortality, you need many patients for that. It's not applicable to Sjögren's for obvious reasons. Cause-specific mortality, again, Sjögren's increases the mortality a little bit, so running such a trial would be impossible. Non-fatal clinical events, that's kind of important, especially if you think of lymphoma. But again, you need thousands of people to run a trial with the outcome of lymphoma in Sjögren's. So again, that's difficult. So we end up with surrogates and symptoms and quality of life. And this should be combined, not divided. And the ESSDAI that we use right now as an endpoint for all our trials, even though it has been validated, even though it has been consensually approved and created and has been used and externally validated, it has some limitations. It has a very high placebo response rate, especially if you use the threshold of 3. But the most important thing is that it's completely meaningless to patients. The patient doesn't come in your office and say, you know, my ESSDAI has raised a little bit, I think it's 6. No, she or he comes to your office and says, I'm not feeling well. So we are trying to create some new responder indices. It's the STAR and the CRESS. To be a respondent for the STAR, you should have either response in one of the two major items, the systemic disease activity and the patient-reported outcomes, and have a score of 5 at the end. So either the two major items or one major or two minor, response in the one major and two minor items. And to be a CRESS responder, CRESS has been developed at the same time. It says the same items, but there are some differences between CRESS and STAR, especially at the definition of the response. To be a responder for CRESS, for the systemic disease activity item in CRESS, you should have a clean ESSDAI that is less than 5 at the end of the study, and all the items are weighted at the same time. Are we moving at the right direction? I think yes, because patient-reported outcomes are included in the response. Asking the patient how does it she or he feels after a treatment is included, but are quite complicated. And I don't know if these composite indices are the best that we can come up with. I don't know if I think we should have a small discussion about endpoints. I think it's super important. What are we asking? What is the main question? What is the main answer we are trying to find when we are starting a clinical trial. Should this be a surrogate endpoint? Should this be a quality of life? Should it be these dryness symptoms? What do you think should be the ideal?
Well, I wanted to go back, now that we were talking about endpoints and what the study is focused on, to the conversation we were having before about the standard of care. So let's say, for example, my daughter, growth hormone was approved for kids with Prader-Willi syndrome. It's standard of care. No one would ever ask a kid with PWS to go off of growth hormone for a clinical trial for a drug for narcolepsy, for example. However, if let's say you're taking a psych medication or something, that's your standard of care, you might be excluded from the trial in that case if that, medication might interfere with the treatment, right? So when you say standard of care, there still could be exclusion criteria. So I just wanted to clarify that. It doesn't mean that everybody will be accepted and will, right?
No, yeah, of course you have some exclusion criteria, but behind the exclusion criteria, there should be a medical, rationale.
Correct.
Of course. But choosing the right endpoint is also a burning point, and we should discuss about. There's no easy solution. That it's easy to criticize, but it's difficult to suggest. There's no easy solution about choosing the optimal primary endpoint. But for Sjogren's disease, for our disease, we should definitely include the reported symptoms, not just scores that include values, blood values that haven't even proved the correlation with the disease trajectory.
Anna has a question.
Not really a question, but I fully agree with Lucas that we should look into the symptom burden because, and I think all Sjogren's patients in the room will relate to this when we go to a medical appointment and our doctor is very happy because our disease activity is slipping. So I'm very happy with your results and we are feeling miserable. We go to work on a presenteeism, not to talk about absenteeism. We can think properly due to brain fog. We are in pain, but our results are excellent. So typically in Sjogren's trials, the end point is disease activity. So not all that is measured matters, and not all that matters can be measured. And we need to humanize clinical trials urgently if we want to get more patients on board. So it was not a question, it's again a statement. Sorry for this.
Thank you.
I'm in love with what you said. That's exactly what I wanted to say. And we see some clinical trials, especially having the umbrella design, that they incorporate the ESSP, they incorporate at least some patient-reported outcomes as a primary endpoint. And I think this again moves towards the right direction. So the endpoint is off. We are okay with that. We approve the primary endpoint. What do we do with the secondary endpoints? And my advice, unless you are experienced reading clinical trials, is that you only focus on the primary endpoint and you take all secondary endpoints with a grain of salt. And I would suggest that because a clinical trial is powered to answer just one question, and all the other questions that we can cherry pick and salami slice usually do not have the power for a confident result. So better stick with the primary endpoint. If the primary endpoint is positive, then it's fine. And we have some results, again, from the literature with trials that were underpowered and had some false positive results. A very good example was a drug called Lartruvo. It's an anti-cancer drug. The trial was published in the Lancet for a rare cancer, including 100 patients and showing some fascinating results, including mortality. So it got accelerated approval in 2006, 100 patients. A follow-up study in JAMA, including 500 patients, showed null results, exactly the same results. So the FDA had to go back and retrieve the drug. So we need to have powered studies, powered enough to answer the primary endpoint, and not overpowered, because overpowered studies can result in statistical significant results, but that have no clinically, they have exactly no, it's completely meaningless clinically. So let's now move on to the last part. When are the results published? We kind of scraped it. We usually get the results when the trial is published, and when the full results when the trial is published, and when we have the peer review process gone through. There are some exceptions, especially when safety is concerned. We can have some results either as an interim analysis that is done to see whether there is harm or there is obvious benefit, and for safety results. But I was very surprised getting prepared for this trial to see that almost 50% of the trials that have been carried out on medicine that we use today have never published their results. And these are usually negative results, creating a publication bias. But it's not just that. And again, I will use an example. There was a drug done in the 80s with an antiarrhythmic drug given to patients after a heart attack. The drug was called lorcidine, and lorcinide, and lorcinide during the trial showed an increased mortality in the patients taking it. The results were published 10 years later.
Wow.
And this resulted in 100,000 deaths that could be affected by similar drugs. So the results were not published, and similar drugs were still in the market. And 10 years later, 1C antiarrhythmic drugs were all prohibited from the use. And these 10 years resulted as an estimation in the US only in 100,000 drugs, 100,000 people dying from 1C antiarrhythmic drugs. So what is the status right now? There is no obligation to formally publish the results. Usually big companies do, even if the trial is negative, but there is no legal framework again to mandate such a thing. So we may fall in the same loophole again in the future.
Anna, can you tell us about Facilitate and right behind you. She knew you were going to ask her.
So, I don't know if any of you in the room ever heard of the Facilitate project, which is an IMI Horizon 2020 project. So we're trying, I'm a member of the DEG group, which means digital, because the meetings are online, advisors group. We're trying to establish together with different experts across the world, not only Europe, a framework, an ethical framework to return clinical trial data to clinical trial participants, and also to reuse this clinical trial data in further research areas, because it's a highly valuable asset that is somewhere we have no idea where, we patients, that could be used for informed decision making. It can shape healthcare systems. It can speed up further research. And the reason why I joined this, I was invited to join, and I'm still very, very motivated with this because of my experience in my clinical trial. So this resulted me in joining this project, this international consortium. I don't know if you've heard of it, but what are your thoughts on clinical trial return to participants and the reuse of it, and how this can change the landscape in the coming years?
Yeah, I'm not, and I'm super excited to learn that there is such a project running right now. And the aspects of withholding data are enormous. You should think about it. It's the government that needs the data. It's the doctors that need the data. It's the patients that need the data. It's the researchers that need the data. It's withholding data from all these parts, from all these people that cooperate. It's I think it's really like a bad thing in the community right now, and we should work all together in order to make it more transparent and to make data that are at the individual level, but also as a whole in studies that are negative or studies that don't go as expected, to publish the data, create large databases that are government, like registries, that should always put their raw data so that can be reanalyzed, so that can be accessed by everyone, so that we can all move on freely and faster.
Exactly, and I don't understand as a patient expert, why is everyone so afraid of sharing negative results? In our own lives, every day we learn from mistakes.
Right.
Yeah.
So it's a huge patient unmet need, knowing when it didn't work, and how, and why, and what can be changed. So we see negative results sharing as something positive, but why is everyone so afraid of sharing this?
Yeah, I don't know if it's the stigma.
Our own experience in clinical routine is trial error.
Yeah, that's true. Sometimes you learn more from failing than you learn from succeeding. And I don't know why there is this hesitancy publicizing the data. Maybe, again, it's the stigma of the trial not gone well, or maybe there is something that there is some kind of fear publicizing the data. But in any case, we should press as a community for publicizing the data. Yeah.
I just want to share that we are already in the right place, because at least in the EU, there's a new clinical trials regulation. It's already in place, and it's now mandatory to publish clinical trial data. Not specifically to each clinical trial participant, but it's mandatory to publish the final results of the study. I believe there's also probably a deadline for the sponsor to do that, and it's now mandatory. So we may not have already many clinical trial results that we should have access to, but now it's in the EU regulation. So if a clinical trial is being conducted and there are no results published after the deadline, then they are not fulfilling the legal requirements. So it's one step forward for clinical trial transparency, which is being increased now.
Yeah, that's good to hear. But does that include negative studies or studies that are halted?
Every study.
Every study.
Yes.
That's good. That's good.
It's a mandatory requirement, even for phase 1 studies, irrespective of the outcome. The primary outcome must be published. So yeah, just from the company's perspective, but indeed, even smaller studies, irrespective of the outcome, there is a timeline indeed when that must be published. I can tell you it can sometimes also be difficult because journals are not always interested in negative data, so it is not always easy to get it published. In the end, you will find a journal, but I have personal experience with many rejections because the data was not very exciting. But yeah, in the end, at least from our perspective, everything will be published at some point.
Yeah, that's good. That's good.
I think we have to wrap up. In
Yeah.
a minute, do you want to give some closing thoughts?
No, but yeah, wrapping things up, I just want to say that clinical trials is I think the epitome of care, and it is the only way we doctors can be confident that what we do really is rooted on the principles of do no harm. This is the only way we can look you in the eyes and be sure that what we are suggesting as treatment really works at the individual level, but also at the whole community. So it's the only way we can move forward and create a solid bond between the patient and the doctor this is all. This is all I have
Perfect.
to say.
Great. Thank
So,
you.
thank you, Maria.
Thank you.
Thanks, everyone.
Can you hear me? Okay. So, this is the last session of our meeting to do this year, and we're going to have to show the PRPs in action, exploring EULAR online course and key achievements. But we have to change the speakers. That Coralie has to present us his speech before Elsa, because she has to leave, okay? She's flying, so we'll just change the... So Coralie is
Thank you.
yours, and
Thank you, Kathy.
she's going to present PRP achievements, and it's the speech, the presentation is very nice.
Thank you, Kathy. Sorry again for this change of work schedule. To conclude, because I was supposed to conclude this 2 days workshop, I wanted to share with you some very concrete examples of involvement of PRPs in research. So our missions, our goals, our challenges is to be patient research partner for Sjögren's disease with, as you can see, some goals. And one of them is to respond to unmet need. Publications and abstracts are regularly published by ourselves, to engage with organization and federation, to have constant link, as you have seen since 2 days, with faculty and pharma companies, and finally to advocate for Sjögren patients everywhere we can. So a couple of, again, very concrete examples, the nomenclature from syndrome to disease. I think it was a huge, huge achievement for the Sjögren community. And I leave you just a quote from a French rheumatologist after we deliver with Cathy Hamid from the Sjögren Foundation the talk and the patient views on nomenclature. She came to me and she said, it's the first time I see the disease like you as a patient. And she told me that that will change the way she will communicate with her own patients. That's one achievement for us all, patient association and federation. So if you remember well, this nomenclature initiative, we participated with Cathy first, Cathy Hamid in the task force, and after that we shared among the community some survey, Delphi round, and so on to have some voice, many answers, because we wanted to avoid Sjögren's autoimmune epithelitis. We also wanted to discard Sjögren's autoimmune exocrinopathy, and so on. But we managed, and thanks to all of you who has participated, we succeeded to change syndrome from disease. Speaking of protocol and study design, I wanted to talk to you briefly about a forum-funded project on stratified medicine in Sjögren. We managed to make changes of the study design. That was the initial plan and the initial grant of the full project. And finally, the final project organization, it's what I said earlier, yesterday. It's possible to change things. It's possible to change the way the study, let's say, has been planned originally, with a little patient somewhere, but not too much. don't involve too much patients, we don't know exactly what to do with them. And finally, when you've got PRPs in that kind of organization, and when the PRPs prove, explain, and show their added value to the project, at the end, it's PRPs involved everywhere, PNPs involved to communicate, to publish, to be co-author. So that can happen, and again, let's get involved in research projects because it works. Professor Fay, that you probably all know, has even published in the final manuscript, the final report, because you know when you are funded by a foundation of rheumatology, you have to publish a report with results and all how the project went. He has said that our views help design the PROs, the patient-reported outcome, but therefore they have decided to use the samples from existing biopsy and not perform new biopsies on patients. So they follow our advice. And that's a huge step. Huge step for the research, huge step for us Sjögren patients, and for the collaboration and communication. So yes, that happens. Clinical research, another part where we can be all very much involved. So you will have enough of STAR, you will have enough of necessity, but still, it's a great project for us, Sjögren patients. STAR, Sjögren tool for assessing response in clinical trials. So we are perfectly in the team. I promise that we didn't prepare with Lucas the same presentation. It was just to explain. It was to explain where the patient has been really meaningful and why STAR is a huge achievement for us patients. So if you see, so if you see there, you won't see there. Okay, so I won't use the laser point. With CRESS, so CRESS is a score to assess the response during a clinical trial. Luca has already talked about it, but what is important for us patients and meaningful is that CRESS, the other score, to be declared positive, CRESS must be above 3 points. And you have the details of the points, and patient-reported outcome is 1 point, exactly as a serological or Tigland. In STAR, so in necessity, again, what you can see is the patient-reported outcome 3 points. The disease activity 3 points. What does that mean for us patients? That means that one clinical trial will be declared positive only and only if there either the systemic disease activity, which is still important for us because if we have organ involvement, we need a treatment to treat the organs, or the patient-reported symptoms. And to be declared positive, a clinical trial with STAR as a composite score, it will be 5 points. So even if the patient included, as Lucas said earlier, has no systemic involvement, so no disease activity, but if it's meaningful on our symptoms, it will be declared positive. And if it's declared positive on our symptoms, we will have access to treatment. And that is thanks to the patient research partner involved in the necessity trial, because we have collaborated with the clinician to develop that score. That was the publication, the official publication of STAR, made by Raphaël Seror from Paris. And Raphaël highlighted in the publication the participation of the patients during the 3 rounds of the Delphi. And it's a recognition and acknowledgement of our work. Another study that we have led within Necessity again, we are all PRPs. We are collaborating with with researchers, with pharma companies. But at the end of the day, do they ask us to come because it is mandatory, or do they ask us to come because they want really our input? It was one question, quite, I must admit, provocative question, but still. We ran that study last year to get the honest feedback of the scientific community, so a lot of researchers and pharma companies, because in necessity you've got 20 faculty, 20 academics, and 4 in the pharmaceutical company. So we led this study, and this study has been published in BMJ, so you can easily find it. And I just wanted to give you a couple of quotes from the clinician. It was, of course, an anonymous survey. I just wanted to give you some quote about that collaboration. Is it about clear communication and mutual appreciation? It is a plus, not a challenge. And it was really interesting. And again, you can go and see that publication online. A very important part of our job as PRP is awareness and co-construction. And one of the good example is OMERACT. So I don't know if you all familiar with OMERACT. OMERACT is an international, let's say, international task force, outcome measures in rheumatology. So OMERACT is led, well, co-chaired by clinicians, of course, but as you can see, Cathy from the Geogran Foundation and myself, we have been involved since the beginning in the working group to define new measures about Sjögren's disease. Multidisciplinary working group, and what's interesting and why I did put that picture is that there's of course a lot of researchers, but Cathy and we are in the life impact. And it was an evidence from the OMERACT working group to invite us to lead the life impact group, because no one else knows about the life impact than us patients. Another interesting collaboration I wanted to show you, a very recent one. It was a poster accepted at ACR last month. One of the unmet needs that we have identified, speaking with you all, when we have these networking times, these exchanges, is that the discrepancy between our perception of our disease, like Anna said earlier, we feel terrible, but the blood tests are perfectly okay. So with Faye, again, and the Novartis team, we have decided to explore with a huge survey, real-world survey with Adelphi data, to explore the difference of perception from the patients, the clinician, and the SCORE-SDI. Again, you will find that online. It has been published. It was just to show you again an example of collaboration between patient organization and research on unmet needs. So, speaking of unmet needs, what we have done so far, we have raised all the neurological issues that are quite never addressed by the research community. So it has led to a European survey and a publication. We also have raised as an unmet need the sexual health issues, very important. And again, it was because we were talking and speaking to you. You know that Anna and myself are involved in the European Reference Network, and they will start a systematic literature review early next year. We will be involved with Anna just to have a picture of sexual health issues in Sjögren. We also work importantly on access to care and treatment with ORDIS and ERN. And we have been involved in all phase 3 ongoing studies. to again and again represent and advocate for patient voice, to make sure that for the phase 3 studies, the patient voice and the patient symptoms are really taken into account, and not only the clinical endpoints to get better results and meaningful results to us. That was a study we have presented at the previous Sjögren's Symposium, again on neurological symptoms, just to make sure that the research community know that it's a very important unmet need for us. And last but not least, what means a lot for us at Sjögren's Europe is to network and exchange with you all, because you know it, we say it in every publication, together we are stronger. Thank you.
Thank you very much, Coralie.
And I take the opportunity to thank you all for this exceptional 2 days of meeting. I'm sorry I won't be able to say goodbye properly because I'm now rushing, but many, many, many thanks for every presentation, every interaction, and every meeting we have. Thank you and see you soon.
Thank you very much. And now let's give the floor to Mrs. Elsa Mateus. Elsa is a patient research partner, is a EUPATI fellow, is the president of RPCDR, which is the Portuguese League of Rheumatic Diseases, and of course it is vice president of EULAR. Okay.
Okay, all right. Usual thing, usual problem. Let's
Do you
see.
want a headphone?
You can see me.
Okay.
Okay, I'm used to this. I don't know why. Okay, so my presentation was to be before the one of Coralie. But first of all, I want to thank you all for inviting me here. For me, it's very important also to be here because I've been following Sjögren's Europe since the very start and supporting Sjögren's Europe since the very start. So for me, it's also very important to be able to contribute to this conference. Okay, so I thought I would, well, you see, we can jump the last one because we already had the examples from Sjögren's community provided by Coralie. But I would like to start by providing some different concepts on patient experience and how they can be used and also understood by the patient's community and patient's organization. I will talk about meaningful engagement and opportunities. So, when it comes to patient expertise and the values of patients being experts on living with their own disease, we have several different concepts that you can find. You can find the term expert patient. You can find the term patient partner, patient expert, and also patient research partner, which has been also very widely spoken here. And I usually like to bring this here because every patient expertise has its own role in patient organizations, and they can be very useful, but we need to be aware of which patient expertise are you using for what. So, let's see what is understood by expert patient.
Expert patient movement. To take care of ourselves, we need help. In 2006, I introduced the term expert patient in Spain. But somehow it has spread the idea that the expert patient is Superman, some kind of almighty person. But Superman does not exist. Or the encyclopedia patient, who knows a lot, but the information is not enough. We have several diets at home, or we can just search for them on Google, but we do not follow them. We know we should exercise and take our medication, etc., but we just don't do it. To know is not the key here. The key is to want and to achieve. The expert patient is the one who lets others help him and helps others in return. To say, yes, I want, and yes, I can. This is not my own saying, but the World Health Organization's one concerning the support to self-care as the key to chronic patients' care. With the health professionals' support, in addition to families and groups, you get the will and the power to achieve. Support groups led by expert patients and supervised by health institutions are the 21st century medicine's revolution. Author Dr. Manuel Serrano Gil.
Okay, so this is a concept of expert patient which is really useful when it comes to peer support and to provide self-management courses, for instance. And sometimes I like to bring this here because sometimes I've assisted that patient organizations try to mix and be confused about the different or similar terms. So expert patient is more, it's very useful to create peer support groups and also to develop self-management courses, because it's the one who will have learned to live with a condition and has also the ability to talk to others and have empathy with others from suffering from the same problem. So now let's see what is out there usually understood by patient partner.
Well, I feel I contribute a lot to the training of the med students and the dental students. I understand in years gone by they didn't see a living person until about the third year. Now they get to see us within a month of starting, and I feel it helps their training considerably if they're dealing with living people. They get an opportunity to make mistakes here, which can be corrected. It also does a lot for me. As a retired man, I don't want to be sitting at home doing nothing. And the fact I've got to learn a lot of scripts helps my brain to keep active.
The Patient Partner Programme is a really good learning experience for us as medical students because it sort of allows us to learn and practice our clinical skills in a safe environment, away from the hustle and bustle of like a real clinical setting like a hospital. It also means that when we are exposed to the hospital setting, we're more prepared and we get more out of that experience.
Okay, so now if you look in Google for what it means, patient partner, usually you find a lot of programs like this. And in these kind of programs, patients who are experts on living with their own disease, they are partners in teaching doctors and health professionals. So they are partnering in medical professional education. So usually when you find this term patient partner programs refers to this, to patients being involved in medical training and helping doctors, health professionals, whatever, to become more knowledgeable about how to handle and how to communicate with patients, how to diagnose and so on. So this is the concept of patient partner. And now we come to another one, which is patient expert.
Patient involvement in medicine's research and development provides value for all stakeholders, including patients, researchers, industry, regulatory bodies, payers, and policymakers. How do we know this? What is the evidence? Research funded by the European Commission highlighted the potential benefits of patient involvement, such as more relevant research priorities from the outset, research methods and results more relevant for patients, therapies and health interventions that are better tailored to patients' needs. Also, patient involvement results in more meaningful outcome measures and may help to improve recruitment and retention in clinical trials. In the rare disease setting, inclusion of patients groups as equal partners has been reported to contribute to the success of research applications and the research conducted. This has resulted in the fact that research funding agencies increasingly require the involvement of patients' organizations. Also, the newly revised International Ethical Guidelines for Health-Related Research involving human subjects have addressed this issue. Different stakeholders agree on the importance of patient involvement, yet it is still not the norm. Why? Patient involvement often lacks structure, and the when, where, why, and how across all stages of medicine's R&D remains a subject of debate. Often there is an inconsistency in approach, and it happens too late. The lack of formal documentation of patient involvement activities complicates the sharing of experience and learnings, preventing timely and systematic implementation. The Yopati roadmap originates from the needs of highlighting the specific opportunities for patients' involvement throughout the different stages of the medicine's R&D lifecycle. Who was involved in the development of the roadmap? This roadmap is the result of a collaborative work including patient organizations, academia, non-governmental organizations, and industry. This roadmap highlights the 4 key stages of the medicine's R&D lifecycle and provides a tool to facilitate patient involvement along the way. The 4 key stages are: research priority setting, research design and planning, research conduct and operations, dissemination, communication, and post-approval activity. Stage 1. Research priority setting. Patient involvement has a vital role in the very early stages of medicine's development to ensure that research priorities meet patient needs. Involving patients will help ensure that development of novel therapies or interventions is focused on patient care areas defined by patients themselves. The involvement of patients in the phase of research priority setting can be about gap analysis, early horizon scanning, matching unmet patient needs with expected research outcomes, defining patient-relevant added value and patient-relevant outcomes. Stage 2. Research design and planning. Involving patients in the design and planning of research contributes to patient-friendly design. At this stage, patient involvement can happen in the following areas. Protocol synopsis. Patient involvement can help define the target population and generate real-life data by including patients with characteristics that represent the target population better. It can also help define the most adequate protocol design. Regarding the protocol design, patient involvement can help to identify relevant endpoints, identify acceptable risk versus potential benefit from the patient perspective, identify appropriate exclusion and inclusion criteria, define diagnosis procedures, select relevant patient-centered outcomes such as quality of life or other patient-reported outcome measures, identify potential issues such as ethical dilemmas or data protection to provide adequate assurance that patient concerns are addressed early in the trial design. Draw attention to operational factors like frequency of visits or the availability of remote monitoring that can impact the ability of patients to take part in trials. There are other areas in which patient involvement is beneficial in the design and planning phase of research, such as fundraising for research. Patient involvement can also help secure research funding and put topics on the research agenda that would otherwise not be considered. Informed consent and patient information. Having patient advice for trial communications can ensure clarity of material in terms of content, visual appearance, design, readability, and language. Materials may include patient information leaflets and consent forms, especially materials used in initial approaches for potential trial participants. Ethical review. Ethics committees in several countries routinely request evidence that end users have been involved in the development of the research and in the development of material intended for patients. Practical considerations. Patient involvement can help identify practical considerations that reflect the diversity of the patient population and their differing situations, such as the need for travel expenses, support for family members, or other obligations that need to be addressed. Stage 3. Research conduct and operations. At this stage, patient involvement allows early identification of difficulties and enables a more accurate impact assessment. Additionally, patient involvement in internal and external communication during this phase is crucial. Patient involvement in research, conduct and operations can arise in the following areas. Patient representatives as members of trial, steering committee and investigators meetings. Patient representatives can ensure a timely patient perspective integration. For example, patient involvement can help anticipate trial recruitment challenges or opportunities, potentially highlight areas of concern to trigger protocol amendments, and improve patient access to trials. Information to trial participants. Patient involvement at this stage can generate protocol amendments. When changes are made to protocols, patient involvement in communicating the changes and the reasons for them is highly valuable, especially if resulting from new safety information, where participants' concerns need to be aligned. Data and Safety Monitoring Committee. In collaboration with data monitoring committees, patient contributions can help assess the impact of study results on real patients, facilitate assessments of side effects, and identify underlying issues related to formulation and administration, adherence, as well as study retention and dropouts. Study reporting. Dissemination of interim results at predetermined study milestones should be an important part of the communication strategy for clinical trials. Involving patients in this process can help communicate the results and their relevance to the wider patients community and can encourage retention. Stage 4. Dissemination, communication, and post-approval activity. A role for patient involvement has also been identified in regulatory affairs, health technology assessment, and post-study communication. Regulatory affairs. A role for patient involvement in regulatory affairs includes development and revision of European Public Assessment Report summaries, an assessment produced for all medicines where marketing authorization is requested through the centralized procedure at the European Medicines Agency. Development of lay summaries of results. Development and revision of package leaflets. Development and revision of updated safety communications. Post-study communication strategies. Patient involvement should be incorporated into post-study communication strategies. For example, in the development of updates, feedback, and thank you letters to participants in lay language. Information sharing can help future patient experience and outcomes. Patient involvement also contributes to the publication and dissemination of research results among the patient and professional communities. Health technology assessment. Patient involvement during the HTA process helps to identify whether the evaluation of patient priorities and patient-relevant outcomes meet the needs and experience of patients as end users of the technology. Patient involvement has a multifaceted impact on research. Thorough preparation, realistic expectations, and a systematic approach to learning from successes and failures will be critical to leveraging the potential of patient involvement. All involved parties, patient organizations and patients, clinicians and researchers, academia and pharmaceutical industry will need to be involved in the identification of strategic points for patient involvement and their implementation to maximize the benefit for all stakeholders. This roadmap also serves as a guide for structuring education and information. The value of training for patients about the R&D process has been proven by the EUPATI Patient Expert Training Program, with a growing number of graduates. UPATI Fellows, actively engaging with the different stakeholders as experts patients. The UPATI online toolbox on medicines R&D, now available in 14 languages, has been accessed by more than 6.5 million individuals since its launch, proving the demand for lay language information on medicines development. UPATI is committed to enhancing patient involvement in research through education.
Okay, so the term patient expert, I think it was most disseminated by the UPATI, European Patients Academy on Therapeutic Innovation. It was a project that was funded, it started in 2012, and you have seen what has come to until now. So it's also a training for patients to become experts and to be able to be involved in all these areas. And one of the things that I wanted also to highlight here is when I was watching the video and I was thinking back on Caroline's presentation, you can see that Children's Europe has done a lot of work when it comes to this kind of patient expertise and providing input to research in a lot of different ways. But it is also a chance for national organizations to try and empower your patient community to become experts and also to help your national organizations at the national level and also to contribute to the Sjogren community. So we also have now going to another concept in another video around patient research partner. I don't know if everyone of you, I've heard a lot of patient research partners today, but I'm not sure if you are really aware of what patient partner is, what patient research partner is. It is a term from EULAR, and we will watch again a video.
Being a patient partner means that I join a research team as an equal member, which means that I have rights and responsibilities. And my responsibility is to bring to the table my personal experience of living with a certain condition and make sure that this perspective is heard and seen in every step of the project. In other words, patients reading about our study must be able to identify with our work and to recognize their own experiences, their needs, etc. And I think this only can be done if the team takes my input really seriously and treat me as an equal, as an expert in my own right. And that means I'm being invited to all meetings, I receive all materials, I'm asked for my opinion, and that I feel safe and welcome and things like that. So it's a two-way process. So I take their input seriously and discuss things when opinions differ and do the things that I'm supposed to do, and I ask for explanations when things are new or difficult to understand.
I am involved in several research projects, including the European Consortium Necessity, focused on Sjogren's disease. PRPs are involved in every single work package where they can bring the patient's perspective, validate some decisions, and give their inputs on the strategic choices.
Patients can have different roles in research. They can be a participant in a study, for instance, in a clinical study in which a new medication is tested. That is not strictly a role of collaboration, though. And when talking about collaborating with researchers, a patient can be a respondent, for instance, in a survey or a focus group. And this is still a one-way collaboration. Or they can be an advisor, for instance, in how to best recruit patients for a study. And then the final decision will be up to the research team. But a role in which your influence as a patient is bigger is as a reviewer, for instance, in a grant application or a manuscript. And this gives a substantial influence on final decisions, but without any formal responsibilities. And finally, a patient research partner, that is a way for a patient to properly collaborate, which means being part of a team and thus share responsibilities and be involved in a long-term two-way relationship. And finally, a patient or a patient association can initiate or fund and conduct research themselves. And in that case, patients are in the lead. But all these roles differ in their commitment, in time commitment, amount of influence in the research process itself, their complexity, and thus in required competences.
The PRP will give his opinion on the design of the study. For example, how many times the patient will have to go to the hospital, how the drug will be administered. The PRP can also give its opinion on the questionnaires used to assess the treatment during the trial, the relevance of the clinical endpoints selected. The PRP will also be asked to review the information and consent sheet to make sure it is understandable by all patients and will help write a lay version of the protocol to give to the patient included in the trial. The PRP can also be asked to communicate toward patient communities about the trial and, most importantly, disseminate the results.
Okay, so we've seen again what is the meaning of being a patient research partner, which means to be someone really involved in a team. We heard two of them, Ingrid and Coralie, and now we will see what we mean by meaningful engagement. Well, in rheumatology, in fact, has a long tradition of involving patients, and it has started in 2002. Or even earlier in the 90s with this OMERACT initiative that was already mentioned. OMERACT, which stands now for Outcome Measures in Clinical Trials, Outcome Measures in Rheumatology. It was before just aiming to RA clinical trials, but nowadays it covers all rheumatology. And this initiative started to involve patients in the early 90s. And since then, they developed all their activities also involving patients. And in 2010, EULAR, which is now the European Alliance of Associations for Rheumatology, has established the definition of patient research partners as persons with a relevant disease who operate as active research team members on an equal basis with professional researchers, adding the benefit of their experiential knowledge to any phase of the project. So this is the current definition of patient research partners, which was disseminated by EULAR. So since 2010, EULAR has been involving patients in every project, and these recommendations, which were published in 2011, were updated recently. But you have available, if in case you are interested, you have available these leaflets, which are the Patient Involvement in Research: A Way to Success, which is a brochure, explaining brochure, and you have also what we call the reference cards about patient involvement in research. They offer some guidance for patients and for researchers on how to work together. So these documents are available online. You can still find it there. In EULAR, after having this concept of patient research partner, they started developing training courses. The first one was 2010, and then they have several other training courses and training opportunities, and the group was growing. So between 2010 and 2019, the number of patient research partners involved in EULAR grew from 17 from the start to 67 in 2019. So we have a lot of PRPs in the EULAR network. In 2023, we have updated the EULAR recommendations for the involvement of patient research partners in rheumatology research. And this is the group of researchers and patient research partners also there. And these are the principles and recommendations on how to involve patient research partners in research. So one of the different things, the new things here, is the notion that we need to have, it's good to have a coordinator, someone that coordinates the patient research partners' involvement in research. and also the issue on the recognition of PRPs from their work. And since 2019, we start developing EULAR, the online course for PRPs. So instead of just those meetings that we used to have as a training face-to-face opportunity, we now have the Patient Research Partners online course available. And another video.
Hello, my name is Mariana and I'm from Portugal. Since my diagnosis, that I felt the need to know more and to do something for myself and for other people with rheumatic diseases. And when I heard about Patient Research Partners, I immediately decided that I wanted to be one because I wanted to contribute for knowledge and to give my perspective to what it is to live with the disease, especially at a young age. One of the main things that the PRP course brought me is the feeling of acceptance of having a disease because I found a new me. I learned how to properly get involved in research, how to give my perspective, and how to have an active role in society. Being in different projects as a PRP allow me to meet a lot of new people with different backgrounds and to understand different methodologies. This helps me to interpret new studies and to understand the interventions that are applied to people with rheumatic diseases.
Okay, so you or your members can register the, I think it's third, I'm not sure if it's third or fourth online course is now starting, so they prolonged the registration period. So you can look for it at the EULAR website and find some more things about the training course. It has a fee, but the fee can be waived if there's a condition. I think you need to, let's say, have a kind of commitment of becoming a patient research partner also for EULAR. Okay, so you can check the conditions there, and if you are interested, you can find something more. So, what is meaningful engagement? A couple of weeks ago, I found out this new framework from WHO regarding meaningful engagement. And this is what is there written as the meaningful participation of individuals who, with lived experience of health conditions, provides powerful expertise and narratives critical to shaping inclusive and equitable health policies, programs, and services. So this is also now under the scope of WHO. So patient engagement and patient involvement, patients' involvement in research and whatever areas, it's nowadays a greater necessity. So we need to empower our patients, the one who wants to do it. And you saw different ways of having people with experience of living with the disease participating and having an active role in your organization. So we need to empower these people to become patient research partners, to become advocates, and to be able to participate in all these different ways of shaping healthcare and healthcare services. So, opportunities. What is out there? Well, as a patient research partner, there are some possible roles that you can see there. In EULAR, we can be involved in recommendation task force as a member. We can be patient reviewer of research proposals or national guidelines. You can be a forum committee member, a reviewer of lay summaries, a member of the European Medicines Agency Committee. And by the way, you can also, as individual patient expert, you can apply to be an individual expert at EMA. So you look for this in the EMA website. You can be a member of a pharmaceutical company advisory committee. You can be a member of International Patient Panel for International Research, a consortia. You can also be a patient research partner in a principal investigation initiated study. and you can be involved in a specific research study or hospital department research projects, etc. So some examples. And the little signs there, the green ones I was already involved, and the yellows I've been involved also sometimes. And just for example, I've been involved in those projects. Some of them are also involved there. Nowadays, the first one was Yarmonix project, which was on Sjogren's disease, and then I started also contributed to the Hippocrates project and the Stratafit, and now from this year on, I was also nominated to be a member of the National Ethics Committee for Clinical Research. So this was also a part of my journey. So I started reviewing lay summaries, and then I started also reviewing some grants, and then I also registered as an individual expert patient in EMA and EMA. I've participated and still participating once in a while in recommendations task force in EULAR. I've been involved in international patient panel in consortia, and I'm one of the authors of the Patient Research Partner online course, and finally now I'm which is a lot of a huge responsibility, a member of the National Ethics Committee for Clinical Research. So this is, it has been my journey. It doesn't have to be yours. You can choose and select whatever area you feel more comfortable with. And this is why it's also very important to take some training courses to be more confident on how to put your expertise, your experience of living with the disease into the research or other settings when it comes to healthcare services. So PRP achievements, that was what Coralie has presented before. So thank you for your attention.
Thank you. Thank you very much, Coralie. Do you have any questions?
I should stand there.
What's at me?
I just wanted to add that Elsa is my captain, my boss. So if I'm here today, it's because of her. Because I had no idea this world of PRPs and contributing to research existed. She is the one and only responsible to push me to get involved. And here we are today. And our national organization is also a founding member of Sjogren Europe. And although it's not her disease, she's an RA patient, she never looked back. She just, go. She gave me wings, and when I didn't want to fly, she pushed me, you know? And I hope that the next time we meet, and now I'm talking to our members, there will be more PRPs in the room. So you have Eupati, you have EULAR, which is more disease-specific, more dedicated to rheumatology. You have the Urardis courses as well. I've done also the winter school at Urardis on scientific innovation and translational research. I've done the EULAR PRP course in the old times when there were only face-to-face meetings. And a PRP is in a permanent learning journey, so you are learning every day. It never stops. It's like Hotel California. You can check out anytime you want, but you can never leave. Thank you.
Elsa, I want to continue with Anna. You have been my mentor all this time, and I would like to thank you for everything you've done for me and the way you taught me how to work. Thank you so much.
So, thank you, Elsa. And me again, and I promise it's the last time you're going to be here at that meeting. So, I have to have a microphone, I think. Here. No, they cannot see me. I'm too tall. So, here we are. We have the end of our meetings for 2024, and we have some closing remarks. Maybe you forgive me, I have to read them because I have written them and I don't remember all of them. So when we organized that meeting was dedicated to clinical trial is to show hope. This is our main objective, to show hope. And that the hope that we have heard in this room over the last 2 days, is what every Sjögren's patient should receive with their diagnosis. And I'm sure that what we will take home from this meeting, more knowledge, more experience, and the certainty that our concerns, the concerns of Sjögren's patients we represent, are echoed in each of the countries represented here. And what else we can do take home? What is our takeaways? It is the certainty, first of all, that there is no treatment without clinical trials. That's for sure. And the second, and the future directions, is that we need to improve the tools for accessing the disease, create new tools, not leave this disease underdiagnosed or misdiagnosed, which is most important. There is an urgent need to improve patient and doctor literacy about this disease. And we needed to develop new treatments, more powerful treatments, and more easier for patients to access them. This is the only way to give to our patients, to Sjögren's patients, and not only for them, the quality of life they deserved. So we keep going. And it is the very good quote that Dr. Divi previously says, hope is allowed. It's a very big quote. So this was our aim. I believe that we managed to have that objectives. I would like, and please Coralie and Joyce come with me. I would like to thank you all for being here. Would like first of all to thank our sponsors, platinum sponsors, which is, let me read, okay, Johnson & Johnson. We know all of them as Janssen, okay, now it's Johnson & Johnson, Novartis. Our gold sponsors, which is Amgen and Bristol Myers Squibb, and our supporter, which is AD Pharma. We also want to thank a very big thank to our technicians there, which is help us to go smoothly all these 2 days. We would a big thanks to my team, which is Amalia and Artemis, and of course Nikki, which is the leader. Thank you, and of course to all of you. We have a rendezvous for October next year, 2025. Which will be a 2 days scientific conference. It's not a meeting. We will let you know. And again, thank you very much for all being here. Last logistic, for those who are remaining and staying at the hotel this night, Saturday, we have arranged a dinner at 7:30 at the restaurant. Okay? Thank you very much for everybody.
And thank you very much, Katie. Thank you, Katie, our big mama. And I said that I wouldn't say anything else, but I forgot something. Collaborative work with all stakeholders as equal partners, paving the way to a better health is the only way forward. This is the message we all should take home. So PRPs are needed. Pharma partners, we will push for them to collaborate, okay? What Trend does is amazing. We can collect that on so many topics, and wow, we need you, and thank you for all you've done, okay? And thank you to all the members. Some of them have traveled from so distant countries. I am lucky because it's my home country, so I didn't have to travel. But thank you, everyone. Thank you again. And again, thank you, Katie. Big Greek mama, the Greek style.